because if you slope the acrylic straight out from the tooth, you have a big bulk there for rubbing with your tongue and your cheek, so you just don't do that. Now that that's done, and you've got your extension, you now know how thin to make it. So that's why you cut the periphery off first. How come you're all so quiet? Depends on how my schedule is running. If I need to do it in a hurry, you know, to stay on time, then I do it that way. If I have a carbide burr in a handpiece, then I would just skim over it to smooth it. But I would start the cuts right here. Maybe this will show. See how you could make a groove? Your teeth are interfering in lateral excursion, or they wouldn't have those red streaks on them. Okay? And this one's interfering. Now, let's see what posterior interference does. Put the ribbon back in. And we have better red streaks, but we've got a little bit of a smudge there that might bother some people. Now, what about that streak we don't like? It's a double one, so why don't we just make this flat right through there like that? And then make this flat across there and put the ribbon in again and see what happens.
What would be the problem with a double streak?
Well, they don't know which one to slide on. It has to be uninhibited with no programming. They come in with their own teeth worn into where they really fit, and we don't need it. You see, we've almost got one streak already. So they're going from the front to the back. What we're going to do is take off this middle part that goes distal and keep the good stuff. Now we can put it back on and see what happens.
Now, when you're in the laboratory adjusting these, are you inclined to use 2 thicknesses of ribbon or just one?
Just one. I use 2. It doesn't matter really, but I use 2 in the mouth when I'm not getting a steady excursion. People are feeling the texture. Go ahead and put that one more time there.
Would you use 2 in the mouth as a matter of routine?
No, I would when I first learned, and I'm trying to get these streaks to really be definite. I would use 2 thicknesses right there. But you notice that all I have to do is take off the part that wiggles and leave the part that would be a straight line. You notice how I keep moving and always polishing it in the direction that the function is. That way I'm creating a smooth excursion on the plastic, not spot grinding and making it rough. Okay? See how easy that appears then if you just take off what you really don't need? We're getting to where I'm getting some group function with the bi. And I think that's okay at first. You see, you're getting your lateral at first here. We don't want it. We'd want it just a little bit. As it travels over, it goes downhill. So right there would be something that you might not see in the mouth, and you could ask them to slide over first and I can see what they're doing, then that part needs adjusting, or maybe this molar needs adjusting. So what you do is you have them slide on what they can feel, and when you get over there, say, keep that in your mind. Now just open enough to let me put the ribbon under. That's great. Do it again. Oh, it shows. Come real close up on that and see if you can tell the difference. And if it doesn't show because it's so tiny, that little green, we can tap on it or use a double thickness. So put it back in there. There's the spot. Now it looks more green. Do you see? And all we have to do and that does it. So now when we come over there, it's on a tooth that's farther forward. And that can release the quiver that happens when cuspids cross over. And if anything back here does, put red back there, and let's see if we can pick up red working excursion on the molar. Okay, now when you're going after a molar, you go straight in like that. When you're going after half an arch, you do this. When you're going after front teeth only, you put it in the same way, and then you come back up on an angle. See, and you get your front teeth, and they don't know what you're doing. Because if you put the ribbon here, they will bite forward. And you won't be checking centric clearance or centrum clearance underneath those front teeth. So the routine, everything from front to back, on an angle, gives you the front teeth without them knowing it, and this gives you front teeth only when they rub around. And when they say the molar's still back there, some tooth is bothering me, good. I think that's wonderful. No, I don't like it. Well, what should we do about it? Go ahead. Put it on the molar.
So you double it over and make it a double thickness.
So they can feel it. Now let's see what shows. Oh, boy, that's what we like. Now put the green in and tap, tap, and we'll know. There's the green. Everything else goes. And that's the most important disclusion feature to benefit more people and more teeth than anything I know. Is that right there?
That is what?
That is called disclusion. Posterior disclusion is more important than a steep cuspid lift.
Just making sure your cuspid is, whatever he comes in with, is steep enough to disclude his posterior teeth.
And that the eminence is steep enough.
Yes.
So the front and the back are steep enough to do it, and if the teeth are worn in and touch too much, then they're not steep enough. So we make the front taller and open up this more. But most everything is opening up the occlusion of the back teeth, leaving the front teeth as they were.
Now, Henry, some of your colleagues would use what's been called a frog eye on the canine. Could you comment on that?
That's because they're opening the mouth wide, extending the thick plastic over under the cuspid to get a faster deprogramming. They haven't had this experience of finding out that they're deprogrammed instantly with freed up posterior occlusion. They don't know that yet. They still have something wonderful to discover. If the patient refuses to wear that big, thick appliance with those extensions, they'll be more comfortable with the little one. But they haven't found that out yet.
Is that a faster and easier way to teach it?
For some people when they're learning. But not for people who've been in the game for a long time and find out the difference between thin and thick. What you see on all these appliances, that whatever we make, we don't want great big thick stuff in front. Do you see? And there is one frog eye over there. in the case. And here's the thin one. So do you see, when you look at how thin this is and how thick this is, you kind of get an idea. And now this is very thin, but it's got one extension. The typical one with full extension would have both cuspids, but you'd have to have it very thick to get the plastic out. The only reason this is a one-eyed is because that's where the cuspid underneath it is. Therefore, that's a harmonious function because the lap over these teeth is the same for every tooth. And it has nothing to do with what the upper jaw occluding is. All these appliances do is give you a little thickness so it can be more shallow, or more open, not as steep, and a little bit of an overlap, uniform all the way around, so that eventually they can slide on plastic rather than their own teeth. Not to change the anterior function. It's to cause the posterior teeth to be more open and have faster disclusion. So that's really about all there is. Posterior disclusion. And that's a pretty good example there that you're looking at. So we have more red on bicuspids and less red on molars.
How far do you take your adjusting in on the articulator before you go to the mouth with it?
I find that I have less chair time if I'll carry it farther right here. So let's have another piece of, and let's have another piece of pie. Let's do what we were talking about. Maybe a couple of, this will be all right here. Shall we simulate the mouth then? Right now, you hold the ribbon and I'll work the patient. We showed that 2 reds, 2 greens last time in the Kleenex. Okay. So I'll have you do the red. And let's see how this does. Let's see how we're going to do it. Okay. Ready? Okay. Oh, good. We got lots of reds. Let's tap on the green then. You don't have to do this when you're working in the lab. You could use a full ribbon if you'd like, or you can go one side or the other. But in the mouth, you have to use double. Why? Because a patient will bite towards the ribbon. Therefore, you put it over here and they bite 2 different ways. If they got a left bite and a right bite, why then that's okay. But if you're trying to make it uniform. This might be the time to just go after the...
Elmore does make Madam Butterfly in a whole arch.
Wide, and you could use that in your lab. Yeah, thank you.
That's even true with shim stock, that a patient will find the shim stock and bite more heavily on it than...
Oh, sure, and then you think you know what you're analyzing. And you're not. They're analyzing. That's really, that is interesting though. Thank you for the... But when you put 2 ribbons in, you're going to find out what they do, and then you analyze the pressure by the ink or the space. See, there's sufficient space, and we want space between those front teeth, don't we? But now, do you see how I'm just clearing out the red? Especially here. This is the most common one right there. The lingual side of the buccal cusps of those lower molars. And that's almost perfect there, so we don't have to do anything. And we'll leave the group function on the cuspids and the bis. Had to sterilize that for just a moment. Okay? Wow, isn't that neat?
Henry, in a busy restorative practice, how much of this would you delegate to an assistant? The
laboratory phase you could. And if she can take it this far, that's good enough. Then I'll take it the rest of the way.
And how much time do you have invested in getting to this point here prior to going to the mouth, on average?
Well, I would say my average is an hour the first visit, so that I can chat with them. If I've got 15 minutes left, then I'll do my impressions and centric and protrusive. Then I'll mount them in the lab. And usually it'll take you a good half hour to make it, because it'll be hard in 3 or 4 minutes. And then you just have to get to work on the lathe and this. And then an hour for relining and seating in the mouth. Give me another. So I have, oh, look. What's the difference? Hardly any red smears at all. I like your ribbon.
Must be more forgiving, huh?
And look at that. This is really exciting for me. There you go. Look at that. I'll even turn it this way. You go ahead, take a look. It's interesting how we don't have a lot of red outside the green, do we?
No.
You do on the molar. And we don't on any of the anterior teeth at all. So we haven't been closing the vertical on this at all.
That's correct.
And so why this makes me happy is because in my physical condition to be able to get this far quickly makes me happy. You see that we could have less of those red, and I like the red and the green on the bicuspids, because then do you see they feel like, oh, I can feel my bite. But they will lose it the minute they start moving on a cuspid only. But that's comfortable when you have a bi and a cuspid both doing it. Yeah, that's really neat. You could almost, I'll tell you what I'll do. I'll put a satin finish on that. Let's see how much it changes the occlusion, because people wonder, you know, after you use these silicone polishing points, if that changes the occlusion. And I've never known it to change the occlusion, because you just automatically polish it the same amount. Because what you're doing is putting just enough of a satin finish on this to get rid of the ink. And obviously you have permission to polish twice as much off the front as you did back here, and then it'll stay level. So if you really have nervous energy and want to do something, I'll do it up here. But what you want to do is watch the monitor when you're doing it. That's the important time. You see? And that always makes the patient feel good when you look in the monitor and adjust their occlusion. Okay, now no smart remarks. Let's get, we'll put it back on here and we'll put some ink back on it and see the difference. Because that then is enough to let the patient go with a satin finish on the occlusion. Okay. Good. And we'll have a little green. And those are working excursions, group function. And that's, and they're good. They're good. But a working excursion over here on the lingual is one of the annoying mysteries. So what we'll do is we'll see if we can pick that one up. That's right. We're going to go then, well, we'll have to do it this way. And you want to move the articulator, and I'll move the, put the ribbon in. You move the articulator over to the working skirt. That's it. Got it? See if you can feel it. Can you feel it there at all? Hold still on it. No? Did I go farther than that? Try it. Farther, 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 farther. Nope, it's open.
It's right in there.
Right there.
It's closer to the centrum.
Is it? Okay.
Or if it's a false, you suppose it's a false
Could,
marking.
must be a false marking. Okay, I'll move it. Yeah, the thing that confused me is the white streak in it. So, I don't know. And that's okay.
So at this point, that's ready to go to the mouth.
It is.
Reline.
Yep.
Henry, on relining, what would you typically see out of all the appliances that you've made? Where do you usually have to make the adjustments in the mouth after you've taken the...
Not in front.
Always in the
It's
back?
always in the back because it's been elevated just a little bit.
Usually in the 12, the second molar region.
Mm-hmm.
How about those times when you would put a small bit of acrylic, a little dome of acrylic in the first molar region and not have any other contact?
I would do that as a first molar pivot to deprogram the patient when I couldn't figure out and they were confused. And just a quick thing, if you put a pivot over molars like a Monument Valley dome and then you had them close, come forward and right there. Now tap, tap there, just where the front teeth touch. And then tap, tap. You'd have a tripod. See two molars in front? And they're perfectly comfortable. I've never known anybody that wasn't comfortable with two first molar pivots under the mesiolingual cusp with a little contact right there. And they could wear that overnight, maybe a few days.
Is that somewhat
Totally
like an anterior
deprogrammed.
repositioning?
It is anterior.
Approach then?
It's opening the bite and anterior repositioning, and then you can give credit to whichever it is, depending on what school of thought you believe. And I don't think it makes a one bit of difference. I just know that a little bit less occlusion in a more forward position, most people will respond to, because that's where the habits are, that's where the clenching is, that's where the wearing down of teeth. The abrasion is always in front of centric. So it gives them a chance to rest forward. So you're thinking of the rest position and the natural occlusion, because now they're going into something different. Then it's so easy to put acrylic behind and in front of that pivot, because you can grind it down. You can open it up so you can have a saucer under both upper first molars. It's very quick and comfortable. It's been a very friendly technique for me when their boss at the office, their husband is sending the child support, the teenager driving her nuts, and she's just a nervous wreck. And you'll do that and have them come back the next day. Do it again. Because you do anterior jigs and things like that, that just throws the stress just where you don't want it. You don't want it with a lateral pterygoid pulling your jaw forward. You don't want the stress in the condyle. You want a resting position. That's the quickest, easiest thing So if it's a patient approach, then it's okay, because you're not doing it to please the gurus who want you to prove your in-centric relation, that it is where it should be, terminally, et cetera, et cetera, et cetera. Just please the patient, and that's just a very pleasing. Because you can just equilibrate it right down to whatever level you want. And then when you put more acrylic up on top for resurfacing, they have a place to go. I used to resurface the whole thing a lot, as you well know. But when I getting into more complicated things, then I got into this pivot and then filling behind and adding behind and in front of it. That's a good question, because that was a dimension that
Okay, and
has
doing
been
that,
recently.
and doing that, putting the pivot over the molars is going to allow the condyles to seat more overnight. Is that correct?
Relax.
Relax, so they're going to seat. So
They're almost seated when they tap on anything.
Yeah. Okay.
I mean, the only way you can make them seat more is by torquing.
Okay.
And that's a pressure thing that you do. The location of where they touch doesn't change like the pressure on those spots. You check that out before you do anything to a patient.
And that spot is a little flat spot, not a little concave point.
It is just like this. It's a centrum area. Okay. It'll have red streaking on it. You could have a crow's foot on that molar.
Okay.
And the molar more so.
Right.
You'd rather do
All
it.
by itself, it'll do it.
Sure.
Don't even need a front tooth.
And you'd rather do it in the molar region than in the first bi region.
Oh, yes.
Because?
Well, because that happens to be the way teeth came into the mouth. That's the way the muscles and then patient adapted to something. It was a center, and it was not too steep. It was a shallow occlusion. It was safe. It was forces were centered, and they could rub around on it. And then when the front teeth matched those molars, 4 incisors and 4 molars had all that a jaw does. Everything else came into function with that. And the first bicuspid is one of the last ones. Thank goodness for a first bi and a cuspid to help you that way. And you saw in this case, the first bicuspids are toed in, aren't they? So actually they have group function in that case. Why not take the appliance out and have group function? I don't know whether we showed that, but that might be a good thing to show. Because that's always been a question on this case. Do you see that the bicuspids were steep? See how the first bi and the cuspid do it? That's why I selected this case, was for that very reason. See that first bicuspid? Right there and right here. Look how wide open these are because of the eminence. But that's perfect group function. That cuspid had already developed its pattern before the cuspid erupted and matched it. How about, well, and then let's put the appliance on and see. Same thing. You can see the red ink. It's exactly the same. Okay. There you go. That's what I wanted to show. I must have gone in protrusive and not realized it. But that's okay. This shows, I'll put it together so that people can watch how the ink got there. Okay? All right? Now we'll do this one. Because you have to do that on your patient to analyze what did they do with their teeth to make that streak so that it transferred from the back to the front and then underneath that lateral. And now in protrusive, that's what the question was. In protrusive, how do you do it? Well, you come forward like that, and there's that central right there producing that red streak. Okay, now what we'll do is we'll put the green in and see if we can... slipped. That's okay, do it again then. Okay. Okay, let's see how that green got there then. No. Try it again. There. There. No. There it is. This is the one we're trying to focus on. Okay? And how did it get there? Well, it looks like it got there with the corner of the central. And it's got a white center to it, and it's stronger than all the other marks. So there's no point in having it around there's no point in having it focused where that stone broke off. Because then that's a twisting on an anterior tooth.
sometimes when I've been adjusting these, I've noticed that I have a rough opposing tooth with a sharp edge on it. How many times will you pick up and
You go like that.
Yes.
You polish the polish the bevel on the labial. And sometimes it's right there on the inside. And right there. It's a So Fu Ceramiste silicone points, and that's what you put all the bevels on those front teeth with. People have mentioned about the cuticle nippers. It's the half jaw cuticle nippers that I find the easiest, and when you're doing them, the most important thing is to clip off a little fin on the labial and a little fin on the lingual between those crooked front teeth. So if you'll go down here on the labial on one side and on the lingual the other, you don't have the fins between the front teeth. Therefore, you could tease it up and down and free it up, but you don't want any plastic catching on those front teeth. And what was the other thing I want? Oh, Bill had given us to show this soft 3M cut and polish wheel. This is for deburring and finishing. It's soft and flexible. And he doesn't then have to use pumice on his appliances. And the other thing I wanted to show that's a little handy hint was those two over there with pink acrylic. When you have like a distal extension partial, it's giving you trouble and they've thrown it away, then you make an appliance, just like a partial denture. And the problem is they probably will like this better than their other partial because it fits the front teeth all the way around, you see, and then doesn't tilt and tip and bind. But you make your appliance and then you do direct acrylic in the mouth on that. And the other one would be when you're doing dentures. You might have a denture problem. You might want to put a pivot on that, or you could just make an appliance over it. That takes care of the occlusion. So between relining it with Line-All Reline and an appliance up on top with a pivot and then full occlusion, you got it made. Because if you can reline this and then put a pivot on your first molar, have them wear it overnight, come back and then do acrylic, you've got the tissue corrected, you've got the occlusion corrected, and you'll know which are the contributing factors to the uncomfortable feelings and the sore spots. So you can trace it, whether it's from the lack of adaptation or inadequate occlusion. And then if this is pretty well settled, but things are changing here, just keep relining it. I've had tissue conditioning go another 1/4 inch down there to where you have hollow ridges. But you have to have something stable up above so when they tap on it, they know where they're at. And it's a consistent. What else were we going to? Oh, give me that one over there with the red wax. That's the one we were looking at before that I was too much. See, if you have too much red wax all over everything, then there'll be such a gap under there that you'll be sucking on it, pressing with your tongue, and it's just very uncomfortable. So that was just an exaggerated situation.
Good day, my name is Jerry Savory. I've had the great blessing of knowing Dr. Henry Tanner for over the last 16 years. When I think of Henry's impact on my life and my career, the term elegant simplicity comes to mind. I frequently think of those times when we've been in study club settings with him, and we all have collectively and individually said to him, Henry, thank you for making so very crystal clear that which should have been blatantly obvious. At the time that I met Dr. Tanner, I had no idea whatsoever that a simple piece of plastic inserted between my patient's teeth would have such a dramatic impact upon my patient's well-being, the well-being of my practice, myself, and my family. Frequently, I ask myself, if someone was to come in and take all of the therapeutic equipment
that I currently have in my office, what would I leave behind? What would I demand for care? And my answer has always been a simple toothbrush and that piece of plastic. I cannot think of another item that helps me communicate with my patient as to what they may be feeling, that helps me see as what am I diagnosing. So for all of that simplicity, that elegant simplicity, Henry, I thank you.